So the upcoming ADA, I'll be debating Mikhail Kosiborod about whether the SGLT2 inhibitors and or the GLP-1 receptor agonists are ready for prime time for primary prevention of atherosclerotic cardiovascular disease. I've worked very closely with Mikhail for over 20 years. We're very close friends, and I look forward to humiliating him on an international stage. So I get assigned that they're not ready for prime time. And most of my answer, I think that SGLT2 inhibitors from the DECLARE and the CANVAS trials data pretty clearly don't affect atherosclerotic cardiovascular disease risk in the primary prevention population. So I think that's a reasonably easy answer if we're talking about 3-point MACE, cardiovascular death, MI, and stroke. The counter to that is in the GLP-1 receptor agonist in general in the meta-analysis, and specifically with dulaglutide in the REWIND trial, the efficacy for atherosclerotic cardiovascular disease outcomes looks to be independent of prevalent atherosclerotic cardiovascular disease. But importantly in REWIND, if you look into the details of the data, the absolute risk reduction in the primary prevention cohort was 0.5%. So that means you have to treat 200 patients for 3 years to derive that single clinical event reduced. And for a drug that's priced often at $300 or $400 a month, it becomes cost prohibitive. So I'm going to use an economics argument for the GLP-1 receptor agonist. Now, flipping back to the SGLT2 inhibitors, if we're talking about primary prevention of cardiovascular death, MI, and stroke, it's a reasonably easy answer. It's a very different answer if you look at heart failure. So I think the SGLT2 inhibitors are in fact ready for prime time for heart failure risk reduction independent of prevalent ASCVD. I think probably we'll need to have multiple risk factors just to get to a level of absolute risk that will justify the absolute risk reduction and the cost efficiency. So I don't think every single patient with type 2 diabetes should be started on an SGLT2 inhibitor to prevent heart failure, but I think we should have a very low bar and not require clinically manifest cardiovascular disease to trigger that decision.